and welcome to GP Notebook TV. My name is Anish Katecha and I'm a GP in South Wales. Today, I'd like to discuss with you the NICE guideline, the NG203 on chronic kidney disease assessment and management that was published in 2021. Now this guideline focuses on key aspects relevant to primary care, and I want to break this down to give you the best take-home messages that I really feel are important for us to pick out in general practice. Now, I thought I'd break this down into two videos, and in the first video, I would like to discuss with you the types of patients we should be testing for CKD and what investigations we should be using. And then in the second part of this series on chronic kidney disease, I'm going to be looking at risk assessment, but also pharmacotherapy. So let's start with who we should be testing for CKD. Now, we should offer testing to adults with risk factors such as diabetes, hypertension, cardiovascular disease, smoking, chronic use of NSAIDs, structural renal tract disease, recurrent renal calculi, and a previous episode of acute kidney injury. If they've got a family history of end-stage renal disease, if they suffer with gout, or you find an incidental detection of hematuria or proteinuria. Now, interestingly, those with an acute kidney injury should be followed up for at least 3 years for the development or progression of CKD. Now, what investigations would we use? Well, when assessing kidney function, we should be using the eGFR creatinine, which labs should report alongside a serum creatinine. However, remember to be cautious about interpreting the eGFR in people with extreme muscle mass or those who've eaten meat before the test. Now, if the eGFR is greater than 90, then an increase in serum creatinine of more than 20% can be used to infer a reduction in kidney function. And we should be mindful that estimates of eGFR become less accurate as the value increases above 60. Now, an eGFR result of less than 60, when there is no previous result to compare against, should be repeated within 2 weeks. For proteinuria, we should be using the urine albumin creatinine ratio, the ACR, rather than the protein creatinine ratio. We should be testing those with diabetes, adults with an eGFR of less than 60, and if there is a strong suspicion of CKD. Don't use reagent strips for proteinuria unless they can measure albumin at low concentrations and express results as ACR. Now, confirm an ACR of between 3 and 70 milligrams per millimole with a subsequent early morning sample. If the initial result is 70 or more, a repeat sample is unnecessary. A confirmed ACR of 3 or more is classed as clinically important proteinuria. If proteinuria is found incidentally on a reagent strip, we should offer testing for CKD using the eGFR creatinine and an ACR. If persistent invisible hematuria, which is regarded as 2 out of 3 positive reagent strips, is present, this should prompt further appropriate investigations in an annual follow-up for proteinuria, an eGFR, and blood pressure monitoring. We should consider investigating anemia if patients' hemoglobin falls to 110 grams per litre or less, or if they're symptomatic. And that would be things like tiredness, lethargy, shortness of breath, or palpitations. Now, when assessing the cause of an anemia, if the eGFR is above 60, then we should be investigating other causes. This is unlikely to be due to CKD. If the eGFR is between 30 and 60, then investigate other causes, but use clinical judgment on the extent of investigation. And if the eGFR is below 30, while CKD often causes anemia, other potential causes should be considered. Now, when classifying CKD in adults, we should be using a combination of the eGFR and the ACR category. And NICE has delineated this really well in a table form. Remember that a decreased eGFR and an increased ACR are associated with an increased risk of adverse outcomes, and in combination, the risk is multiplied. These should be clearly communicated to the patient. I think we do that really well in primary care. Now, a renal ultrasound should be offered to adults with CKD who have an accelerated progression of CKD, those with visible or persistent invisible hematuria, symptoms of urinary tract obstruction, those with a family history of polycystic kidney disease, or an eGFR of less than 30. Now, regarding monitoring frequency, you should agree this with the patient, considering individual factors. And again, the NICE guidance is really, really helpful here. And lastly, for this specific video in this series, I feel it's important for us to recognize the definition of an accelerated progression of CKD, which can be a sustained decrease in eGFR of 25% or more, and a change in the eGFR category within 12 months, or a sustained decrease in eGFR of 15 per year, as this suggests an increased risk of possible end-stage renal disease. So, I hope you found this initial video in this two-part series on CKD useful, and in the next video I'd like to cover risk assessment and pharmacotherapy of CKD. Thank you.